So today I'm going to be talking to everybody about invoicing Alberta Healthcare for patient emails. Okay, the health service code that you would use for invoicing for emails to Alberta Healthcare would be the 03.01S. And this is for physician to patient secure electronic communications. Now we're going to dive a little bit deeper into the governing rules around the use of this code and what exactly secure electronic communication means. So first, we're going to start looking at the rules for emailing patients. Um, you can claim it for medically necessary advice or follow-up that is required in regards to managing the patient's care that is sent via over secure email. It may only be claimed when the service provided is being used by a secure email system that is compliant with the CPSA guidelines for electronic communications, as well as that there's been information submitted to the OIPC in regards to your privacy impact assessment for this service. Now, what does that really mean? That basically means that in order to be emailing patients, it needs to be done from a secure system. That means not using your Gmail or your Yahoo account associated with the clinic. It would need to be from a Health Information Act approved system, such as Clinic Connects, as well as Ocean. If you're a MedAccess user, Ocean is one of their systems. So it would be using through one of those actual systems that are compliant with all the privacy legislation, as well as any of the CPSA standards on guidelines for secure electronic communications. Because the most important thing is that we're keeping that patient information protected and that they're being able to access it in a way that is not throwing it out into the general ether of the internet as well. So that's why it is recommended, well, not recommended, it is required that emailing to patients be done through a secure email system. Now, if you currently don't have one, and you would like one, whatever EMR system you are using will have different add-on companies or even one maybe internally that does offer that secured email systems. They're rather cost effective and can be quite helpful with being able to increase patient care that way, as well as and they are sent over secure systems. So that way you would be able to send something, for example, a form they had you fill out for them, let's say a lab requisition, if they needed some copy of some information for something, because it is sent over a secured system, you can send that sensitive patient identifying information to them if they are requiring it. Another one of the rules related to using this code is it may only be claimed for those patients that have established a physician-patient relationship over the last 12 months. So you may find that billing for your locums that are sending emails may not be covered. It's more for the physicians that are doing the more paneled care, or if they're not necessarily looking after a panel, but have been looking after that patient numerous times over the previous 12 months. You can usually bill for that email as long as the physician in question that the email is being billed under has seen the patient previously at least once or twice. And the service may not be claimed if it is provided by a physician proxy. Now, does that mean that the physician actually has to be the one hitting the submit button for the email? No, it doesn't. But realistically, when a physician is asking a team member to send out an email on their behalf, they're giving them the information that they want sent. So they are transcribing and giving them the task together on what they want sent out to the patient. So that is the physician taking care of it. When they say not provided by a physician proxy, that would be more in the essence of emails were being sent out to the patient in regards to something related to, let's say the clinic's going to be closed for a week for renovations. Those would not be considered a billable email because, and again, we're sent out more from a proxy and not for medically defined care from the physician. Now, documentation is very important in your EMR. If you are using a Health Information Act approved EMR system, or sorry, email system, that documentation through the metadata is it within your EMR. But that does mean that you still need to have charting in relation to it. Whether that was you were requesting the MOA to send out a copy of the blood requisition to the patient via email, it's always great to document that in the EMR so there always is that medical record instead of just that verbal request. I will note too as well that the email service code is not fee modifier applicable. So it is just the basic base code for it with no applicable modifiers allowed. And each time that you bill for an email, it is worth $20. I know that doesn't sound like a lot, but over time it does add up. Now, there are a few caveats to billing with it. It can only be claimed once per week per physician per patient to a maximum of 14 email claims per week for that physician. Now, I know that doesn't sound like a lot, but that 14 is actually something that when you think about on average, that's $20 a piece. You're looking at being able to bring in revenue that would cover the cost that it would take for, and then some, for being able to have these different these secure email systems within your system. So they essentially do pay for themselves. Now, I will caution you when it comes to using your billing codes for emailing. It can be a little like using a secret decoder ring. It is not payable in the same calendar week that a 03.05JR took place, or during the same calendar week where a 03.01T took place. And in addition, to make it even more complicated for us, a visit service, so a 03.03A, a 08.19G, any type of visit service cannot be claimed if provided within the 24 hours following the email. So for example, if you sent out an email to a patient today at noon, you would not be able to, and if they were coming in for a patient visit tomorrow in the clinic, it would not allow you to bill for both the email today and the patient visit tomorrow. Now, I know that may seem a little complicated, and you kind of don't want to get caught up in sending one bill in when the other one's not there. So I'm going to show you a trick that I use when it comes to billing for my physician emails. Okay, and before I do, I will just cover this once again, that it may not be claimed when done by a physician proxy. Documentation of the service is needed. And this is very important. This code is not to be claimed for when receiving an email and that from a patient, and then you're calling the patient to book them to come in for an appointment, for a face-to-face appointment. It's more for that email communication back and forth that it's used for. Okay, so one of the tricks that I use, because there are so many weird kind of rules around codes that you can use the 24 hours prior to, or 24 hours after sending an email and during that week, what I tend to do is I tend to look at it backward looking. For example, with it coming up now, the almost June, what I would do by about the end of the first week in June is I would look to make sure that all of my bills for my physician in May were already put, all their visits and procedure bills had already been coded and submitted. So then that way there would be no conflicting opportunities when I went to go look at the email, the list of emails that have been sent. Now, if you're using a secure platform like Ocean, I'll use that as an example, within the MedAccess EMR, you can go into the task lists. Now, if you go into the task lists and you change it down to the consignment MD, you're able to actually pull for each physician the emails that were sent for last month. Now, what I do is I go in there and I look at the previous last month, and then I will go through each of the emails to make sure that there is no conflicting billing for that same date. Did they happen to see the patient on the same day or the next day? Were there one of those, that's, for example, that 03.05JR, did that transpire in the week that email took place? If I find that all of those items didn't take place and it is a billable service, I then add in the health service code and bill it for the physician. But I do find, and I do highly recommend that if you are billing for emails, you do it from a backward looking standpoint. And the number one reason is, and I've seen this happen and it drives me absolutely crazy, is, for example, a patient comes in for a complete physical. And later that day, due to communications back and forth, you ended up requiring having to send also an email. Now you billed both of them at the same time. Or perhaps you build the email before you build the actual visit. Now, what will happen, unfortunately, is Alberta Healthcare tends to pay for the email and doesn't tend to pay for the visit. And being able to get that reversed and going back and forth with them can take quite some time to be able to get that corrected. It's not something that happens quickly. So that's why I do recommend looking at that backward looking mindset when billing for your emails. So by the end of the first week of each month is a good time to look at the previous months if your physicians are up to date on all their billings for that month. Now, some great strategies for success that I would highly recommend for emailing patients is you got to have a secure email platform. Again, if you are sending emails out from your clinic, from your Gmail accounts, your Yahoo accounts, your Outlook accounts, that is not compliant, and I suggest you stop doing that immediately. Another strategy for success is making sure before you're billing for that email is that you're reviewing for any billing conflicts, because the last thing you want to do is get paid for an email and miss out on a complete visit health service code instead. And my third one that I would recommend is having a standardized clinical email process, whether that be through a secure platform, whether that be a process of what, when, and how gets sent to a patient, is working with your team, your MOA, your clinic management, even your referral coordinators in regards to what your standardized clinical email process is and when things are sent out. And another good question that I would recommend asking for your billing agents in your clinic is when they bill for your emails, how they bill for your emails, and to be honest, if they're even billing for your emails. Because I'll be completely honest, I've seen across a lot of clinics where the emails are not being billed for. And if you have 10 physicians in your clinic and they are all emailing patients each and every week, and they can bill up to 14 emails per week, that's revenue that does add up. So I highly recommend looking into and asking your billing staff, your clinic manager, are we emailing patients? How are we emailing them? How is that billed for? And to find out if they actually are. Now, if they're not billing for your emails, make sure to share this code with them, because you will make a clinic manager very happy if they're not aware that they could be billing for them. I know this one was a little bit shorter than normal today, with it being that we're billing for emails. There is not a lot that's besides the rules related around them to go into in regards to just that. So I am going to open up the floor for questions. But before I do, we will not be having a webinar next week, as we will be away at a conference for the day. But our next webinar will be on June 11th. And I am happy to announce that this one is going to be specifically about Med Access and PC-PCM dashboards. We have built out some amazing dashboard items in the Med Access EMR to be able to track your patient panel, your patient breakdown by the high different demographics, as well as being able to track your panel for the number of patients you have that are active, as well as how many of your patients are seeing other doctors within your clinic and how many patients that you may be seeing of other physicians in your clinic. All very important data when it comes to participating in the new PC-PCM. This will be an amazing session, not just for physicians, but also for clinic managers, quality coordinators, screening coordinators, anyone that is helping out with that panel management aspect for family physicians. This does take it a little bit different than the chronic disease management dashboards, as this one is more focused on the business side of it, as well as managing the panel in order to be in accordance with the PC-PCM, as well as monitoring it to make sure that you are not violating the offloading regulations of patients to other physicians, and to make sure that there is opportunity if you do see a bit of a shift in some of your patients being seen elsewhere, to be able to correct that immediately before your panels start to drop. So please Join us on June 11th at 12 p.m. as we will be taking a deep dive into MedAccess and PCM dashboards. And we will also be giving out in that webinar a booklet that will walk you through step by step how to build all those items on your MedAccess dashboard. And another announcement I'd like to make is here at Oslo Medical Billing Tools, we have the CMGP calculator and the Track My Time app. CMGP calculator is for the fee-for-service model physician, and the Track My Time app is for the physician that is working under the new PCPCM. We are proud to announce that we are going to be launching some pilot projects across the province here in the next few weeks, and we are looking for clinics and physicians that would be interested in participating in utilizing one of these tools depending on the healthcare model that they are practicing under. And I have a special announcement that we are actually even going to be integrating AI into the Track My Time app here shortly within the next couple of weeks. We want to make it so that way the tools that we are giving you, you will have the ability to talk to them and they will talk back to you. And that's what we are going to be testing next in our Track My Time. So we are looking for pilot project attendees, whether you be a family physician, a clinic manager, or a clinic as a whole. If that is something that you may be interested in or know somebody that may, please have them reach out directly to me at Oslo Medical Billing Tools, and we would be happy to set them up with that. Or if they're just interested in seeing one of the demos and related to the tools and how that can help increase their clinical revenue as well as their physician revenue up to a minimum of $95,000 a year. So I will now open up the floor to questions. If anybody has any questions in regards to patient emails, or if you have any questions in any other billing questions, I'm here to answer those too.